Good afternoon, everyone. My name is Dr. Jody Guest. I'm an infectious disease epidemiologist and professor and vice chair in the Department of Epidemiology at Rollins School of Public Health at Emory University. Since March, I've been leading Emory's COVID-19 outbreak response team working in hard-hit communities in Georgia. It is my pleasure today to moderate this event and to be joined by Dr. Ken Thorpe and Mr. Bob Bixby today as we discuss healthcare costs in the era of a pandemic. Today, you will be hearing from two experts on federal budget and health policy. Mr. Bob Bixby is the executive director of the Concord Coalition, a nonpartisan organization that encourages fiscal responsibility in Washington and helps educate the public about the federal budget and the need to protect our children and future generations from excessive government debt. Mr. Bixby joined the Concord Coalition after serving as the chief staff attorney of the Court of Appeals of Virginia. He has served as a member of the Bipartisan Policy Center's Debt Reduction Task Force, which produced a model plan for comprehensive fiscal reform. He speaks frequently around the country on the nation's fiscal challenges and possible bipartisan solutions, including greater government efficiency, tax reform, and improvements in the entitlement program, as well as testifying at congressional hearings on these issues. We are also joined today by Dr. Ken Thorpe, who is the Robert W. Woodruff Professor and Chair of the Department of Health Policy and Management in the Rollins School of Public Health of Emory University. Dr. Thorpe was Deputy Assistant Secretary for Health Policy in the U.S. Department of Health and Human Services from 1993 to 1995 in the Clinton administration. In this capacity, he coordinated all financial estimates and program impacts of President Clinton's healthcare reform proposals for the White House and directed the administration's estimation efforts in dealing with congressional healthcare reform proposals. He also testified in congressional hearings and is a prolific author and frequent national presenter on issues of healthcare financing, insurance, and healthcare reform. After we hear from both of our experts today, we will have time for questions. So please use the Q&A function to send questions to us. And before we begin, I want to put this conversation in context with our latest COVID-19 numbers in the United States. So for your COVID-19 update, unfortunately, I do not have particularly great news for the United States. We have now reached a milestone of more than 10.5 million cases of COVID-19 since this pandemic began in the United States. We have 20% of the world's burden of cases in only 4.2% of the world's population. Looking at our case numbers, I want to caution everyone to recognize that the 14-day previous data are usually underestimates. So the numbers that you see climbing here are likely to be backfilled and be higher in future weeks. As of yesterday, we reached a new pandemic high of 130,989 new cases diagnosed yesterday. As you can see, these numbers have been climbing steadily. And we originally had our first peak at the beginning of May and our second peak in the middle of July. And since then, we have gone down and we have steadily gone up in the past month and a half. Additionally, looking at hospitalizations, we reached another high peak yesterday of number of people hospitalized with COVID-19 in the United States. This number as of yesterday was almost 62,000 people who were hospitalized with COVID-19. Again, this is our highest number of hospitalizations since this pandemic began. When we look at deaths, the numbers are less, and I want to make sure everyone recognizes the timing of this. Cases are diagnosed, 3 to 4 weeks later, we see hospitalizations peak, and 4 to 6 weeks later, we see deaths increase. Hopefully, this will not be a trend that continues, but it is a trend that we have seen consistently throughout this entire pandemic. Currently, we have, as of yesterday, had 1,347 deaths in the United States from COVID-19. Our high was back in May, on May 7th, at 2,752 deaths from COVID-19 in one day. Cumulatively, though, we have lost almost 250,000 people from COVID-19 in the United States. Additionally, as we look at states across the US and who is having the biggest increases, we see most of our states are in red with growing, increasing numbers of cases. 44 our states As of yesterday, we're in the uncontained pandemic category, according to the global epidemics from Harvard University. None of our states are in the green, which is controlled, and only one state is within the ability to contain with current approaches to the pandemic, which is Hawaii. And lastly, there was a good piece of news yesterday from CDC where they showed data that masking not only protects those around you, but also has the ability to protect you. So as we see some states start to consider masking mandates, we want to make sure that the message is out there. This is not only to stop the spread to the community, but also to protect you when you're out in the community. And with that, that is our COVID-19 update. And we are going to turn to Mr. Bob Bixby next. Again, after that, we will hear from Dr. Ken Thorpe.
Thank you, Jody. My job today is to try to put into context COVID-19 in the shadow of debt, so to speak, within the context of the federal budget, which is what the Concord Coalition is focused on, is having a sustainable fiscal outlook. And this COVID-19 outbreak has, since the beginning of the year, raised significant problems with the economy and the budget, to the extent that it really becomes an overriding force. So that for those that are worried about federal fiscal policy and the budget and the debt, you can't really expect the budget situation to improve until the economy improves. And you can't really expect the economy to improve until we get COVID-19 under control, for reasons that I'll go into. The federal budget is now the federal budget deficit. I'm having, let's see, I can advance here. The deficit is often thought of as termites in the basement. It's a problem that is not readily visible to people, and so it doesn't get quite as much attention as you would get with a wolf at the door. The problem right now is that we really do have a wolf at the door, and it is the COVID-19 problem, but we also still have the termites in the basement. So as we think about this, I want to try to distinguish between those two problems and what they mean for fiscal policy and healthcare policy when we think about that wolf at the door, COVID-19, and the underlying structural budget deficit, which also has a lot to do with healthcare over the long term. First point is that the budget was already on a bad track, a rising debt track before COVID-19 hit. This shows you debt to GDP, which is the most relevant measure of the debt. And what it's showing is that we were already into close to record high territory simply because of policy choices that we had made, because spending is rising faster than revenues pretty much on autopilot. And so it had nothing to do with a pandemic or an emergency or something like World War II, which you saw the previous spike. As I mentioned, it's caused by an underlying structural gap in spending and revenues. Spending, for various reasons, which I'll get to, tends to go up faster than revenues. So if Congress just did nothing, we would have a rising debt to GDP ratio, because spending is on an autopilot set to grow faster than revenues. Those are the termites in the basement. Now, for a little bit at the wolf at the door, when COVID hit, Congress responded very promptly, appropriately, and in a bipartisan way with 4 bills that were aimed at going after the virus, treating the virus, healthcare costs, and significantly treating the economic effects. Because remember, what had to happen was to slow the spread of the virus. Various governors around the country began to impose lockdown orders, shutdown orders, telling people not to go out, telling businesses to close up. So there was a deliberate kind of a self-induced coma imposed on the economy. So the government in that situation very appropriately needs to come in with a huge amount of support to try to get individuals, businesses, state and local governments over the hurdle. I'm not going to get into the details about what has happened since July, when many of these relief efforts have expired. There's probably going to be some other relief bill, but the point is that Congress appropriately reacted very aggressively, and that had a huge effect on the federal budget deficit, which again wasn't in good shape going into this. We already had a baseline expected deficit of over $1 trillion, which, take my word for it, is pretty unusual for a good economy and something alarming. But as a result of the COVID-19 response, the budget ended the year over $3 trillion. It's expected in the current fiscal year that we're in, 2021, it's probably going to be close to $2 trillion. So we've got some sort of COVID hangover in the budget. It affects the economy. There was a huge, I mean, this is the magnitude of it. For people that worry about the government spending too much money, this was an unprecedented sort of crisis that hit suddenly and very, very deeply, as these numbers show. Now it shows that in the most recent quarter, GDP picked up, and there may be, and that's a good thing, but it doesn't mean that we're out of the woods, because we're still about 3.5% below where we began the year. As a 3.5% real GDP growth is below where we were. So even when you make up a lot in one quarter, as we just did, you're bouncing from the low point, so the percentage kind of looks a little bit more impressive than it is. Point is, we're still down, and Jody's numbers foreshadow something very troubling about this, because if what happens before happens again, that is, if the virus becomes so widespread that we're going to have more shutdowns, lockdowns, you're going to see that GDP number stall or go down again, what economists sometimes call a W, or you could call it a double dip recession. I'm not seeing that right now, but it's something to be concerned about. How does this translate to individuals? Well, the unemployment rate spiked, as you can see, and has slowly trended downward since then. But again, in a kind of a troubling way, it's remained stubbornly high, and the new weekly claims for unemployment have remained way above previous records. So a caveat on the recovery is that it may be slowing, and people worry about the long-term effects. That gets back to what we do relative to the budget, which is that our COVID problems don't end. Our budget problems don't end when COVID does. This shows that we will resume a path of rising deficits and debt after the effects of COVID fade. I'm going to just fast forward a little bit here to tie in healthcare, because when we get back to those termites in the basement, the long-term health of the budget is very much tied to federal spending on healthcare. It's about a third of the budget right now, and it's projected to grow even more. When you look at CBO's long-term projections, most of the growth comes from, on a programmatic sense, comes from healthcare programs, Medicare, Medicaid, primarily. This also shows, by the way, that if you continue to run big budget deficits, your biggest problem is going to be interest on the debt. And these projections assume very low interest rates going forward. So that's something to look at, as interest rates and costs are low now, but as the economy recovers, those will become more of a problem. To put this in context right now, if you look at the major healthcare programs plus Social Security plus net interest and exclude everything else, all discretionary spending, defense, education, transportation, anything, the budget is on track to just have those three categories consume all revenues by 2036, which is just giving you some sense of the size of the problem. Medicare is bigger than Medicaid and is growing faster. So Medicare reform is going to be important. Where does the growth come from? A lot of it just comes from the aging of the population, but more importantly, it comes from healthcare cost inflation, what economists call excess cost growth. And that's where reforms can have some effect. You can't do much about the aging population. We're here, we boomers are here, we're retiring, we're collecting Medicare, but we do have to look at the efficiency of healthcare delivery. One final point I want to make, because it affects the long-term economy, is the big slowdown in workforce growth. When you look at projected long-term economic growth, the projections are slower than past economic growth. And it's not because the CBO or others are just being pessimistic about things, they're counting heads. And what happens is our workforce, because of demographics, is growing much more slowly, and that has implications for how fast the economy can grow. So I will turn things over to Ken, not an overly optimistic follow-on to Jody's not very optimistic follow-on. We've got some tough healthcare and budgetary numbers to contend with. Ken?
Good afternoon, everybody. Again, thanks for joining us. And it's a pleasure to join both Jody and Bob here today on this panel. I'm going to talk a little bit about healthcare going forward. And the near-term news is really even, I think, a little bit grimmer than Jody painted. She gave us the really bad numbers on COVID in terms of new cases, hospitalization rates, the aggregate number of deaths. But the broader impact COVID has had in the healthcare system in the near term has been quite debilitating. If you look at the impact it's had on different types of healthcare services, particularly preventive services, such as colonoscopies, mammographies, detection of type 2 diabetes, the whole range of clinical preventive services, they are down 60% per 100,000 people. So we've seen a dramatic reduction in clinical preventive services. We've seen a dramatic and a similar reduction in elective surgeries. The implications of this reduction in preventive services over time could be quite substantial. If we're not detecting these diseases earlier, conditions like type 2 diabetes, heart disease, and so on, it is going to add over time to healthcare costs. We know that the growth in chronic illness is the leading driver of rising healthcare spending. It accounts for 90% of what we spend in healthcare. And our failure to detect these issues in the short term could have some long-term implications. So the COVID impact is quite broad in terms of how it's affecting our healthcare system. So I'm going to switch over now to President-elect Biden and what's likely to come forward in a Biden administration starting next year. As you all have seen, he has started out by appointing a coronavirus task force. And that task force is going to come up with recommendations, I think, in the very, very near future that could potentially and likely be implemented by working with state and local governments and the private sector. At the top of the list certainly is going to be the broader use of preventive services that we know are effective in slowing the transmission, wearing a mask. We have pretty good data that shows that states that had mask mandates and higher use of masks also had generally lower rates of coronavirus. So finding ways to encourage the broader use of masks, more testing, social distancing, public health measures like washing your hands, those are all going to be front and center. We know that a vaccine is coming. I mean, the best guesstimates of the timing of that in terms of broad use of the vaccine and broad access to the vaccine are probably not until sometime next year in the April timeframe. So the big challenge I think the task force has is what do we do between now and then? And we've been talking with some of the members on some more aggressive measures that we could take right now with technology. I've been doing a lot of research on the technology of what kills COVID. And there's really two technologies out there that right now kill the virus, the SARS virus that leads to COVID. One is our air filter systems. There's a heated air filter system available. A lot of companies, hotels, Walt Disney World are using this, and it immediately and instantaneously kills the coronavirus. That's something that if we had a more wide adoption of that type of heated air filter system, we could kill COVID. Many schools are using it. So to Bob's point, I think if we took a more aggressive measure here of implementing technologies like these heated air filters, we could reopen the economy a little bit faster, and we could reopen the schools a little bit faster as well. So that's one. The second technology that we're encouraging the task force to look at is a mechanical kill. So this is a spray. It's a very interesting nanotechnology that actually you can come into a hotel, restaurant, office building, a house, and with a spray twice a month. And the technology of the spray, when the coronavirus lands on it, it kills it instantaneously. So again, just taking a sort of a two-part strategy, a little bit more aggressive while we wait for the vaccine to come, of actually putting technologies into place that actually kill the virus right now, I think is something that we're hoping that the task force considers and makes more widely available. So that's certainly something that we're hoping for. I think the pandemic raises a broader issue, however, of what do we do going forward in terms of rethinking our public health infrastructure. Obviously, it's very complicated, it's fragmented, the supply chains weren't there, it wasn't coordinated. Going forward, we need to put forth a more agile system that has almost an auto response to any type of large-scale pandemic, any type of public health emergency. So we really need to think through very carefully how we're going to reorganize our public health infrastructure, re-engineer it to make it more agile so that it can very, very quickly respond to any type of emerging threat. And I think that's going to be a big area of emphasis in a Biden administration to put in place. So task one is coronavirus. Task two, you've heard the president talked a lot about, is building on the Affordable Care Act. As you know, Supreme Court started to listen to oral arguments yesterday on overturning it. At least 5 of the justices were, it sounded in terms of their questioning and the nature of their responses, were leaning towards a favorable view of it. I always have to be cautious about this because the nature of the questions they ask and how they respond does not indicate necessarily how they're going to vote. But certainly the issue at hand has always been, there are 10 titles in the Affordable Care Act. There are 2 dealing with insurance coverage, subsidies, and the mandate. There are 8 other titles that have nothing to do with that. They have to do with value-based purchasing, the Medicare drug benefit, quality of care issues, and so on. Clearly unrelated to anything with respect to the tax that was associated with not purchasing insurance. So there's some hope that that will stay in place, but we'll have to see. So what would Biden do? He's going to focus on expanding coverage. And I think one of the exciting things he's been focused on is making primary care universally available. We know that having more primary care doctors per capita in a community is associated with lower per capita spending. And so what a Biden administration is going to focus on is building up the primary care workforce, making primary care universally available, starting with the uninsured, as a way to start to expand coverage. So there'll be a big focus on primary care. There's going to be a big focus on continuing to reduce the number of uninsured. We did cover 20 million people through the Affordable Care Act, but there's a long way to go to get more and more people covered. And the way he's going to do that is by increasing the federal subsidies associated with purchasing insurance. So he wants to make it less expensive out of pocket to buy a healthcare plan compared to what it is today. We know that essentially for every % reduction in what you pay out of pocket for a plan, you're going to get about a 0.5% increase in enrollment. So there'll be a big focus on reducing those subsidies in a whole variety of ways. A second thing he's going to do, and this is sort of a compromise solution dealing with both the centrists and the left on healthcare reform, is making a public option that looks like Medicare or something akin to that available when you purchase insurance through the health insurance exchanges. It's going to be a controversial issue because Medicare pays healthcare providers about 40 to 50% less than what you typically find in a private health insurance plan. So the public option is clearly going to be much, much less expensive than the existing private plans you see in the exchanges. And so there's a concern, certainly among the health insurance industry, that this is a long-term approach that could eventually drive most of private insurance out of business, but we'll have to see how it's structured. We'll have to see what the payment rates look like and so on. The good news, though, about the public option is that it's going to be made immediately to the 5 million individuals who live in states like Georgia that did not expand Medicaid. So there was an opportunity in the plan to expand Medicaid up to 138% of poverty. In the first initial years, the federal government was paying 100% of the cost of that. Long term, the federal government is paying 90% of the cost of that. So he would make the public option available and provide health insurance coverage to low-income residents of states like Georgia that didn't expand coverage right away as well. On to Bob's point is, what are we going to do to make healthcare more affordable? And the president-elect has put out a couple of things, and just for the sake of time, I won't go into too much detail. There has been a big focus on drug prices. And my personal take on this is that, yes, some brand drug prices have gone up high. And the vice president wants to do is allow Medicare to negotiate drug prices with manufacturers. The real issue, though, on drug prices, to me, is what people pay out of pocket. And that's been the problem. So there are certainly other proposals that are going to be floating around to limit what people pay out of pocket to purchase, particularly brand drugs. And there's some really interesting work being done now in the Medicare Advantage program called value-based purchasing that essentially says that for certain types of medications to treat type 2 diabetes, COPD, hypertension, lipids, where we know the medications are critical in the management of those conditions, that there should be no copays. Copays in that sense don't make any sense because you don't want to deter people from filling and refilling the prescriptions. You want people to take them in order to make sure that you're managing those chronic conditions. So think there'll be a lot of focus not only on aggregate drug prices, but what people pay out of pocket. And just to give you sort of an interesting statistic, the studies show that for seniors that have 4 or more chronic conditions, if you reduce what they pay out of pocket to purchase the medications to treat those by $1, you save overall in the Medicare program $1.80 because you have reduced hospitalizations, lower clinic visits, and lower rates of ER visits. So again, just myopic focus just on drugs is really got to be thought through in the context of the broader impacts it has on overall spending. But there'll be a lot of focus on prescription drugs. And finally, what we're going to end up with, there will be a big focus on accelerating the migration away from fee-for-service payments. The vast majority of what we pay healthcare providers is on a unit basis, a fee-for-service basis. You do a procedure, you do an office visit, you do a diagnostic test, you get paid based on the volume of those tests. And there's been a growing transition away from fee-for-service into payments that are more bundled. I'll give you a really quick example of a bundled payment would be for a knee replacement. Medicare has gone to a system, not entirely, but largely, where they will pay the hospital a target amount of money for a knee replacement that covers the hospitalization plus 90 days post-discharge. So if you do it more effectively and efficiently, if you get patients out of the hospital faster, if you cut readmissions to the hospital, if you have the appropriate post-acute care placement, not necessarily skilled nursing facilities, but home health, there's an opportunity to share in the profits. So that's, again, these value-based models are designed to try to promote better quality, better value at lower costs. And I think there's going to be a fairly substantial acceleration of these types of models that over time could make an enormous impact on the per capita rate of growth in healthcare spending. Obviously, his health policy agenda is much broader than that. But in the near term, I think that those are going to be sort of the key moving parts. It's the coverage piece, and obviously the coronavirus piece, and the affordability component.
Great. Thank you so much, Ken and Bob. We've got several questions from the audience. I'm going to start with one more generally, and then the next one actually it probably goes to you and I, Ken. The first one is about communication. We have had a lot of issues with communication about COVID-19 and getting the appropriate public health messaging out there. I wonder what your thoughts are on the best form of a positive communication about slowing opening of businesses, or at this point in time, maybe even stopping businesses, which feels like an economic issue, is actually our best public health prevention, and how that ends up being a positive gain for our economy. Could either one of you speak to that?
Well, I think that that is the way it needs to be framed. And I think that after January 20th, there'll be a different communications method in that regard, because that sort of thing has to come from the top, almost as a warlike thing, rallying the country to have a unified stance against a common enemy. And that really did not characterize the current administration's approach to this. So I think that is going to be particularly important because of the statistics that you showed at the beginning with the spike. I think that if you look at, say, a model of communication that Governor Cuomo had in the spring when New York was under such assault from COVID, I think worked very effectively, almost a fireside chat approach. You don't have to do it daily, but I think that having a trusted figure come out, and it shouldn't be the president, I don't think, but I mean, if you have somebody coming out and just sort of explaining the numbers, just being factually oriented, not hair on fire, not, just saying, here are the numbers, here are the consequences of those numbers, and here's what we can do. I think that you're going to get a lot more cooperation from people that way than if, say, you took the one extreme of the current administration approach. You could go in the opposite direction. You could have somebody say, we're shutting down. That's it. Everybody just stay at home. And the public wouldn't react well to that, and they wouldn't stay at home. And the pandemic would spread because the public would ignore such a message. So I think we have a real good opportunity here to sort of start over again on that communications front. But you really just have to start with the facts, lead people along, and show them the positive good they can do. And I can tell you one more thing is that, look, I get this all the time with the federal budget. People say, well, you say it's, on an unsustainable track. What can I do about it? And that's a difficult question to ask with an abstract. That's a difficult question to answer with an abstract issue like government debt. If you can tell people the problem like this, well, you can wear a mask. There are certain steps that individuals can do to help bring the virus under control, and that's the sort of messaging that needs to be done.
Great.
Yeah,
So
I think that's right. I mean, we need clear, unified messages on public health measures like mask wearing, social distancing, and so on, that hopefully coming in January come from both our political leaders and scientists. So we need to be on the same page in terms of the message. So that's going to help. But I think at the same time, on the business side, we can certainly mitigate some of the potential for closing on business if we start to more broadly adopt these technologies that I was talking about. Putting into place technologies that kill the airborne virus. It also kills anthrax, among other types of viruses, as well as using the mechanical kill spray. So we have the technologies in place that if we were more broadly adopting and using them, in addition to the public health measures, would mitigate some of the economic pain going forward that we potentially would feel.
And I just want to add too that it's okay, fellow budget deficit hawks, if we have to spend a lot more up front to do that, because we got to save the economy before we can save the budget, and that means defeating the virus.
Great, thank you for that. So fair to say that wearing a mask is helping the economy?
I would say so.
Okay. So here in Georgia, I'm actually going to come to our more specific healthcare question in a moment. Here in Georgia, our voters are going to decide the U.S. Senate control on January 5th. And in the meantime, can we expect the Congress or the current administration to pass anything significant? Or do you think we're going to be waiting until January 20th?
Yeah, there's nothing significant pass between now and next year. At most, they're going to agree on what's called a continuing resolution, just to spend at current levels on the budget. So I think in terms of any type of legislative activity of any consequence, we're pretty much done for the year.
Okay.
Yeah, I agree with that. And it's unfortunate, but there's ambiguity in the economic statistics, and so you can draw from either side can draw from that, because there is a recovery going on. So, folks that don't want a more aggressive approach at the moment can say, well, the economy is recovering, so that justifies not doing anything. On the other hand, if you look at the damage that's already done and the high level of damage that continues, even with the past rescue plans, there's a strong case for more. And I think they're probably going to wait and see exactly how the Georgia Senate races pan out before there'll be consensus to do anything.
Okay, thank you. All eyes on Georgia, which we're not used to in politics, I will say, and started last week and continuing for us. We're going to move into a question that we got from the audience for medical experts. Speaking about the Great Barrington Declaration. And for those of you listening who don't know what that is, it was a declaration signed by some very smart scientists that suggested that we needed to approach COVID-19 as a herd immunity opportunity. And it is not exactly the way Sweden approached their control of COVID-19, but it is similar, and it's building on some of the same principles. There was pushback from the public health community in an additional memorandum called the John Snow Memorandum, signed by 80 of us across the country, that suggested that this was not the right approach, and instead actually was a way to put a great deal of our nation at risk and to have increasing rates of death when we should actually be working hard to quell the number of deaths that we're getting from COVID-19. So Ken, I'm going to turn to you first and ask you your thoughts on the Great Barrington Declaration and how it might impact the economy and our numbers across the country.
Well, I think that the important thing is that we actually have some international data that can speak to this particular issue. Sweden, although they didn't really, in the full sense, do herd immunity, they did something quite akin to it. And if you compare the outcomes in Sweden in terms of coronavirus cases, mortality rates per 100,000 population, compared to Denmark, Netherlands, Belgium, all of their neighboring countries, Sweden is way off the charts in terms of mortality rates and new cases. Those other countries closed a little bit early, so they shut things down. They had very extensive testing and contact tracing measures in place. So they approached it very different than Sweden. And I think the results in Sweden speak for themselves in terms of the impact that a full herd immunity type approach would have.
Yep. As we wrote the memorandum debating the Great Barrington Declaration, one of the things we pointed out was our hospitals are not capable of handling the capacity that would happen and the overflow that would happen if we were to allow COVID-19 to spread unmitigated across our country. In addition to just number of deaths, we would have deaths that were because hospital numbers could not handle. That is from both a bed perspective and a workflow perspective. We cannot overwork our healthcare heroes in that capacity. And so that was a real major consideration as we thought this through. It's also just COVID-19 has an infection rate and a death rate that is not akin to most things that we're used to seeing that spread in a pandemic. And that is one of the reasons why it also, this idea of natural herd immunity without herd immunity from a vaccination is not something that public health officials generally support. All right. Anything else? We have about 2 minutes until we're done. Is there anything else that either one of you would like to leave our listeners with today?
Well, I think on the healthcare side, I think there's real room for optimism. I think that in the near term, if we're more aggressive before the vaccine comes out, we can actually do something positively to actually kill the virus and enhance the prevalence and the use of these clearly effective public health prevention measures. So I feel good about that. I'm hoping that the Supreme Court does uphold the key areas of the Affordable Care Act so we can build on it and make healthcare more affordable and continue to expand coverage to low-income uninsured populations so that they have access to healthcare. So on the healthcare front, I'm feeling good on that side. I think we can even in Republican Senate, I think there's an opportunity to work with the Leader McConnell on building incrementally on the Affordable Care Act. I think once the Trump administration has moved away, I think the climate on the Republican side in Washington is not going to be dramatically changed, but it's going to be different. So I feel optimistic on our approach to dealing with coronavirus if we can take advantage of these technologies and also to really build something more substantial in terms of affordability and coverage.
And I would just underline, Jody, that I think it's really important to distinguish between the short-term fight against the coronavirus and the longer-term healthcare underlying structural issues that Ken was talking about earlier. And I can't wait to get back to talking about those. I do think there is an opportunity to address some of the cost, quality, and access issues that are out there. The fact that there is such a divided Congress, divided in terms of political affiliations. There are frustrations to that. There are also advantages and opportunities to that, which is in order to get anything done. And there are some ideas out there that do have some bipartisan support, that you're going to need some people from both sides to be able to push them. And it could be that once we get beyond the pandemic phase, and actually getting the pandemic under control may be a motive, give some momentum to broader, you might be able to establish some working coalitions that would translate into some gains in the broader healthcare reform.
Great. Thank you, both of you, for all of this. I certainly do hope that we can move to a spot where public health, while always political, will go back to a bipartisan conversation and really stay above divided politics. I think we've got an example in front of us where that is something our country needs. And hopefully we'll see that with our new administration. I want to comment on the fact that many, many wonderful questions came in that we've not had time for. And if you would like, there is the opportunity for us to answer them through the webinar link after this is over. And additionally, you can forward them to concordcoalition.org and they will be answered as well from there. So thank you, Bob Bixby. Thank you, Dr. Ken Thorpe, for joining today. Thank you for Concord Coalition for hosting this on their Zoom webinar and for the collaboration with Emory's Rollins School of Public Health today. Everyone have a great afternoon and please wear your masks.
Thank you.
Thanks.